Thank you so much, Michael. Welcome to everybody. It's very exciting. This is the first day of HPV Week in Canada. It's now our 4th year. We started in 2017, and I'm delighted to have you with me. This presentation, as Michael mentioned, is partly live and partly pre-recorded because Dr. Shelly McNeil could not make the exact time. But we've got a very exciting week, and the programs will be on our website so that they can be looked at a second time or by others who couldn't make this, this meeting. This week we're doing webinars every day, and today we're talking some general issues in terms of epidemiology and vaccine about HPV in adult women. Tomorrow's webinar will be Dr. Gina Ogilvie, and if you're not familiar with Dr. Ogilvie, she is a brilliant researcher in British Columbia. She received $10 million from the government last year for her work and research. And what she's looking at is, what she's going to talk about tomorrow is self-sampling and the whole issue of reaching out to women who don't have access or easy access to healthcare. This is probably more and more important as we find that it's difficult to get to see the doctor, and it may be more difficult because of COVID and risk of infections. So self-sampling may be a way to keep women not just engaged in their health, but actually looking at prevention of cancers by picking up HPV early in the situation. On Wednesday, our medical students are going to be showing the movie Lady Ganga, a story of a woman with cervical cancer and her impact on a small community in India. It's an 18-minute movie, and after the movie, our two residents will be speaking about their experience caring for women in the hospital, how that affected them, and why they're connected to HPV forevermore. On Thursday, Dr. Anjali Mahutra, who is the Director of Women's Health for the First Nations group in BC, will be talking about cultural issues, cultural sensitivity, and safety, why some women are reluctant to come to the doctor, reluctant to be seen, reluctant to be screened, and how we as healthcare professionals can be sensitive to those issues and how we can do better. And finally, on Friday, Dr. Monique Bertrand, who is a past president of the Federation, will be talking on giving a summary of HPV Week and a summary of HPV, and she'll be doing that presentation in French. So I think we've got a fantastic week. We've already had more than 7 million hits on some of the PR that we've been doing about HPV Week and about HPV vaccine. And whether it's fortuitous or unfortunate depends on how you look at the situation, but a number of the provinces are no longer doing their public health immunization in the school system. And so there's been a lot of discussion as HPV now is being brought into the community once again and out of the school system, at least for this year, because of the overflow work of COVID. So we've got a lot to think about. We want to get people immunized, and we've got a lot to talk about. In terms of the presentation today, most of you know me, but for those of you that don't, I'm a past president of the Federation of Medical Women of Canada. I am the chair of HPV Week for the Federation, and I'm an assistant professor in the Department of Family and Community Medicine at the University of Toronto. Dr. Shelly McNeil, who's going to be the first speaker, is a professor of medicine and infectious diseases at Dalhousie University. She is the deputy director of the Canadian Centre for Vaccinology. She's the former chair of the NACI Committee on Immunization for the HPV Working Group. And Shelly has been working very hard on COVID right now and advising the Premier of Nova Scotia about some of the issues. So we understand that she could be with us in person. These are our disclaimers. Both Shelly and I have the privilege of doing a lot of teaching, working with a lot of different sponsors. And Dr. Denise Black, who is the slide kit developer, has worked with a number of sponsors as well. So I will suggest that I will take all the issues that come up and answer on behalf of both Dr. Denise Black and Dr. Shelly McNeil, and I'll give you what is guideline-driven answers and what is my personal opinion so that you're aware of the difference. But as physicians, we all collaborate, and I'm honored to present on both their behalves. The objectives are to look a little bit at the epidemiology of HPV-associated disease, the immunology and some of the issues around modeling of this disease, looking at screening, how we screen and what are the limitations, Then we'll talk about the available HPV vaccines in Canada, some efficacy and safety data, and there's brand new data out of Sweden last week that's really exciting. And then looking at our Canadian recommendations and some barriers to vaccine. So without further ado, I'm going to turn this over to Shelly, and we'll look at what she recorded for us last night.
Thanks very much, Dr. Brown, for that invitation, for that introduction, and thanks so much for having me.
I think it froze. Michael, do you want to try it again?
Sometimes happens. You have to unshare and start sharing again.
Today, it's exciting to be here to talk about the epidemiology of HPV-associated disease. I'm just going to run through some of that, and then we'll move on to talk about vaccines. So as many of you know, HPV is a cancer-causing virus that's associated with a large morbidity and mortality worldwide. It's estimated that HPV is associated with about 630,000 new cases of cancer worldwide that can be directly attributable to the HPV virus. HPV affects both men and women, leading to cancers both in the urogenital area as well as in the head and neck.
Apologies.
Amongst the cancers caused by HPVs, cancer of the cervix is the most closely associated cancer. With cervical cancer, virtually 90 to 100% of lesions can be found to contain HPV, and HPV is a required cause of cervical cancer. It's also a significant cause of anal cancer, with about 88 to 91% of those lesions having HPV, and then to a lesser extent in the other areas in which cancer is commonly caused. In Canada, there's a considerable morbidity and mortality recorded each year due to HPV. You can see here in this pyramid that the bulk of disease is caused by external genital warts in both men and women, and also oropharyngeal cancer, dominant in men, but certainly still a problem in women. And then, of course, cervical cancer here. Lesser numbers, although not insignificant, obviously, of vulvar and vaginal cancer, anal cancer in both men and women, and penile cancer in men. In fact, in 2012, 11,079 people died from HPV. In Canada, about 38% of those were due to cancers of the cervix, 32% due to cancer of the oropharynx, and lesser due to other sites of cancer, including 15% who died of cancer of the vulva, 8% of the anus, 4% of the vagina, and 4% were penile cancers. Cervical cancer itself is the second most common malignancy in the world. In women. In 2005, it was estimated that about 1 million women had cervical cancer, and about 250,000 died from the disease. In Canada, the peak incidence of cervical cancer occurs in young, in the early 40s, between 40 and 44, where the cervical cancer incidence rate was 16.6 cases per 100,000 women. As you might expect, the incidence of mortality lags the incidence of cancer, and therefore mortality occurs in older women. While many factors have been associated with persistent infection and progression of HPV infection to malignancy and higher grade abnormalities, older age is by far the dominant factor, risk factor for both progression and persistence. Women over the age of 25 are more likely to have persistent infection, and high-grade squamous intraepithelial lesions occurring in older women have an increased risk of progressing to carcinoma. While there are over 100 types of HPV that can cause disease in humans, the vast majority of malignancies and benign diseases associated with HPV are caused by 9 HPV types. HPV type 6 and 11 are the most significant causes of external genital warts. And amongst cancer-causing strains, HPV 16, 18, 31, 33, 45, 52, and 58, the so-called high-risk HPV types, are associated with the vast majority of malignancies. Interestingly, HPV 16 and 18, the early dominant causes of cervical cancer, are associated with younger women and do tend to peak around 25 to 29 years of age and then decline as women get older, both when you're referring to CIN2 plus lesions as well as cervical cancer by age. In contrast, the next most common HPV types, 31, 33, 45, 52, and 58, increase as women age, and the proportion of both CIN2 and malignancy associated with these other HPV types increases as women age. In this Danish cohort study that involved over 2.7 million women recorded between 1978 and 2012, it was important to note that women who had been diagnosed with a high-grade cervical dysplasia were later had ongoing higher risk of other non-cervical anogenital cancers. Here you can see that in women who had CIN3 identified at some point, they went on to have about a 4-fold risk of anal cancer and vulvar cancer and a 17-fold risk of vaginal cancer, relative compared to those women who had never had CIN2 or 3. This increased risk of non-cervical anogenital cancers persists long-term, and in fact in CIN3, in women who have had a history of CIN3 lesions, their risk of anal cancer, vulvar cancer, and vaginal cancer persists out over 25 years. Talk a little bit about HPV immunology. So part of the success of the HPV virus is that it manages largely to evade the immune system, thus giving women, well, all people with HPV-related disease, very little immunity against future infection. So normally when a pathogen enters the host and it has contact with blood and lymphatics, and that gives it a chance to flag the innate immune system and develop an innate immune response to attempt to neutralize the viral infection. The innate system then triggers or activates the adaptive immune response, and antibodies are produced, which should, in many infections, prevent further infection with the same organism. Unfortunately, HPV is a smart virus, so it is a virus that's exclusively intraepithelial. So it invades the intraepithelial cells of the anogenital tract and head and neck and provides no exposure of the blood or lymphatics to the virus itself. Thus, there's not much opportunity for the virus to activate an adaptive immune response, nor for you to go on to develop antibodies, which provide lifelong or any significant protection. While about 50 to 60% of women who have had an HPV infection will develop a seroresponse or will have antibodies detectable, they remain at risk of recurrent infection with the same HPV virus type. The rate of recurrence of HPV infections with similar types as a woman has been infected with before is highest among older women, suggesting perhaps some waning of the original immunity. So if you look overall, there's certainly a risk of reactivation of reinfection with similar strains of HPV of about 2 per 100 woman years. But this is mostly seen in the older women, the over 35 group, and lesser so in the younger group, perhaps again owing to some better protection early on after infection. Another important thing to think about when thinking about HPV in adult women is that while the risk of acquiring HPV infection is certainly highest in younger women early on after the onset of sexual activity, older women continue to develop HPV as their HPV infection as they perhaps encounter new partners. So up to 30% of adult women will acquire an HPV infection, over 5 years. In terms of how HPV causes disease, this is a basic natural history model of HPV infection and its progression to cervical cancer. So early on, women will often become infected with HPV, and it will be transient. And women, particularly younger women, are very able to clear HPV virus. And so they may have HPV present at one point in time, and then shortly later it would not be detectable again. Unfortunately, some of the high-risk viruses are able to go on to cause persistent infection, and over a time period of somewhere around 9 to 15 years, some of those will progress to low-grade dysplasia of the cervix, onto high-grade dysplasia, and then a smaller proportion will develop invasive cancer. And this is, of course, what we're trying to capture when we're doing Pap smears, these early periods of dysplasia, in order to avoid the development of invasive cancer. Also, an important consideration is the HPV acquisition and reactivation, or the proportion of each in older women. This was again a cohort study involving about 700 women, 35 to 60 years of age, who were followed twice a year for 2 years. And over that time period, 13% of incident detections of HPV were attributed to sexual partners. Interestingly, though, 85% of incident detections occurred during periods of sexual abstinence or monogamy, suggesting that HPV infection can remain dormant for decades and then react later in life as the immune system declines and is less able to contain it intraepithelially. So HPV infection, HPV vaccination, of course, then could prevent initial infection and this much later development of reactivated virus later in life. In this modeling study, the investigators attempted to model the time of HPV acquisition relative to the contribution to SYN3+ in women by age group. So here you can see that amongst younger women, of course, the bulk of the disease is caused by a virus acquired early in life, so under the age of 30, but some proportion is still caused by later in life disease acquisition. And as women get older, more of the disease associated with HPV is related to a virus acquired at an older age, so over the age of 30, and sometimes even in the case of older women, virus that could have been acquired over the age of 50. And this all reflects the latency period of the virus I showed you before. When thinking about vaccines, of course, it's important to think about whether women will be protected from a vaccine if they're already sexually active. The reason that we give the vaccine prior to initiation of sexual activity is to try to capture women before they've been already infected with the strains of virus in the vaccine. However, it's really important to note that in the trials that led to the licensure of HPV-4, no women in North America were positive for all 9 HPV types contained in the new 9-valent or nonavalent HPV vaccine. So amongst that group that were involved in the original HPV-4 vaccine trials, about 70% had no HPV infections at baseline. And remember that these were all sexually active young women. None of them, as I said, were positive for all 9 HPV types in the nonavalent vaccine. And only about 21% were positive for any HPV type at the time of their enrollment in the trial. So let's talk a little bit about screening and limitations. Of course, the primary preventative strategy used to prevent cervical cancer for many years has been the use of Pap smears prior to the advent of vaccination. And we know that despite excellent Pap screening programs in many countries, we aren't able to prevent all episodes of cervical cancer. And this has several reasons. Of course, the largest reason is that women are either not screened at all or haven't been screened in a sufficient period of time. So no previous screening or too long ago represents the biggest chunk of why we miss some of these lesions. But there is about a 20 to 25% risk of false negative results with a Pap smear. And these are largely due to sampling errors. So you just miss the area of the cervix and the cells that have demonstrated changes, but they may be due to pathologist error or undercalling by technologists or pathologists. And then about 8 to 15% of them are due to inadequate follow-up. So an abnormal Pap test is done, the result is abnormal, and for whatever reason, the woman is lost to follow-up or inappropriate follow-up is attempted. And then less commonly, treatment failure or rapid progression of disease where the Pap is just too late to have made a difference. It's also important to remember that Pap testing does not prevent genital warts or non-cervical cancers. Most notably, adenocarcinoma of the cervix occurs in the endocervix, typically beyond the reach of Pap of sampling instruments, so it's not detected by Pap smears. About 80 to 85% of them are caused by HPV 16 and 18, and they do tend to be faster growing and more advanced at the time of detection, probably because they are missed by Paps. And now they comprise about 25% of all cervical cancer diagnosed in Canada. Therefore, we need to find a better way to identify these cancers where Pap is inadequate. So there's been much discussion, of course, as you know, about whether we need a new test. We clearly, Dr. Brown's going to talk about the role of vaccination in the prevention of HPV-related cervical cancer, but we also would like to pair that, of course, with good screening tests that could help detect the virus in those women who go on to develop abnormalities. This is important because cervical cancer rates have not decreased appreciably in the last several years. And as I mentioned, the incidence and proportion of adenocarcinomas of the cervix is rising, and we know we will miss those on Pap. Current screening tests are not designed for detection of non-squamous cervical cancer, such as the adenos, and the proportion of women diagnosed with invasive cervical cancer within 3 years of their last screening test, so in shorter intervals, is increasing. So this is a Canadian study done by Dr. Gina Ogilvie out of British Columbia. And the study enrolled women 25 years of age to 65 years of age from a population-based screening study in British Columbia. Women were randomized to the intervention arm, which included primary HPV testing with reflex cytology. So if high-risk HPV was detected, they went on to have liquid-based cytology. Versus a control arm in which was the way we more typically do this, with primary liquid-based cytology followed by reflex HPV testing. And the important take home here is that the HPV test was much more sensitive in detecting both SIN2 and SIN3. You can see here the incidence detected by primary HPV testing was about maybe 1.5 times as good as that of primary liquid-based cytology. And referrals to colposcopy appropriately were done significantly more often in women who had primary HPV testing. The endpoint of the same study at 48 months was histologically confirmed cumulative incidence of SIN3+, 48 months following that randomization. And you can see again that amongst all participants, SIN3+ was detected. SIN3+, the incidence of SIN3+ was about 58% lower in those women who had primary HPV testing than in those who had liquid-based cytology. Amongst those who were negative at baseline, that reduction was even more significant at 75%. So again, HPV testing has a much higher negative predictive value. It has both higher negative predictive values and also will pick up much more disease earlier on. So with that, I'm going to turn it back over to Dr. Brown to talk to you about vaccines available for the prevention of HPV. Thanks so much for having me.
Thank you, Shelly. I just want to be sure that my screen can be seen. Michael, can you see the screen now?
Yes, I can.
Okay. So that was a really good overview of the epidemiology, a little bit about the immunology, and a little bit of understanding of why HPV testing is more accurate than liquid-based cytology. And just for those of you that may not be familiar, liquid-based cytology is just the formal name of doing a Pap test. That's Pap tests versus HPV primary screening. So let's move on and talk about the vaccines. Basically, Canada was one of the first countries in the world that approved HPV vaccines, and we approved the first vaccine, the quadrivalent vaccine, which is here. It had 6 and 11, which affects the subtypes that are typical for genital warts, as well as 16 and 18, the true oncogenic subtypes of virus. The bivalent vaccine came out in 2010, and that only had 16 and 18, so there was no benefit in terms of preventing warts. But again, it covered 16 and 18, the cancer-causing genotypes. HPV-9 came out in 2015 with 6 and 11, 16 and 18, and these extra 5 subtypes that are associated with disease, with cancer, and particularly in women who are slightly older. Initially, the vaccine was approved for women 9 to 45 and men 9 to 26, but recently the product monograph has been changed and it's now approved for men and women 9 to 45. That's the approval on the product monograph. What we know is that the following diseases are associated, and that's for women: cervical cancer, vulvar-vaginal cancer, genital warts, anal intraepithelial cancers, VIN and vein, so vaginal cancers, and vulvar cancers. In men, anal cancer, anal intraepithelial neoplasia, as well as genital warts. So what we look at with HPV-9 is a broader spectrum vaccine covering more subtypes than either the quadrivalent vaccine or the bivalent vaccine. Notably, in the US, they've now changed the indication so that in men, it now includes prevention of head and neck cancers. So stay tuned as we watch the evolution of this vaccine and the efficacy in terms of preventing cancers in different places. Now let's look at HPV immunization in adult women. First of all, we know that we saw a significant reduction when we used the quadrivalent vaccine, particularly in younger women, aged 24 to 34. We saw a 91% reduction of CIN any grade, as well as external genital lesions. In women who were slightly older, between 35 and 45, we saw an 84% reduction. So significant reduction in terms of efficacy. And that was exciting. And that was the data that sort of launched the vaccines. When we look at the impact of vaccination on Pap abnormalities, we saw significant reduction in ASCUS, in LSIL or worse, in ASC high risk, in HSIL. We saw, again, women at the end of the study period having less and less and less disease. And what we know is with the 9-valent vaccine, it's now been, there's been observation over the last 6 years. And what we see is a 66% reduction in the subtypes 16 and 18. And when you look at the other subtypes, there's a 96 to 97% reduction. So we're seeing, again, great efficacy and reduction of all the subtypes that are involved. People always want to know, well, how long-term is this? Am I going to need a booster? Is this vaccine going to protect me ongoing? And I think when we look at some of the quadrivalent data, it's particularly reassuring because it's got the longest years of follow-up. So this is now 14 years of follow-up with the quadrivalent vaccine, 10 years of follow-up, 10 years of follow-up in boys, and now 8 years of follow-up of the 9-valent vaccine. And there has been no vaccine type breakthrough case during this long-term follow-up period with sustained immunogenicity. I think this is, really important if we go back to what Dr. McNeil was talking about, that this is an epithelial virus, and yet we're getting long-term immunity with the vaccine more than we get with natural immunity, because the vaccine ends up giving us innate and antibody response, where natural infection does not. So as we look at this follow-up, it's much better than having had a natural infection. And that's very exciting because we can talk about the efficacy of the vaccine in a very powerful way. And that's what patients care about. Patients care about vaccine safety and vaccine efficacy. Excuse the spelling there. Well, let's look first at the safety issue. There has been more than 20 million doses of the 9-valent. There has been many doses, millions of doses of the quadrivalent. The analysis in all age groups from all these studies, from all the different monitoring bodies like the World Health Organization, the CDC, Health Canada, there has been very, very rare instances of any kind of significant adverse event. These vaccines are generally well tolerated, and the adverse event profile is similar to the quadrivalent vaccine. So it's consistent with the data from pre-licensure trials, and that's very reassuring. The common side effects are dizziness, syncope, headache, and injection site reactions, and that's common with most vaccines. We also know that there's been a review in terms of Guillain-Barré, and there's been no association. There's been a review in terms of complex regional pain syndromes, postural orthostatic tachycardia syndrome, premature ovarian failure, venous thromboembolism. There's no association. And so we can say with confidence that there's no new adverse events and concerns, and these vaccines are very safe. 270 million doses now since 2006. So that's what patients want to know. They want to know that it is a safe vaccine, and I think we can say that with confidence. They also want to know about efficacy. And this is some of the most recent data. The Swedish data came out last week that showed the risk of cervical cancer among participants who initiated vaccination before age 17 was 88% lower than those who had never been vaccinated. Similarly, in Finland, they showed no HPV-related cancers in vaccinated women compared to 10 cases in unvaccinated women. And the US continues to show lower incidence of cervical cancer among girls and women age 15 to 34 during the post-vaccination period compared to the pre-vaccination period. So we've got global publications, we're doing excellent work, and they continue to support each other in their findings. When we look at the benefit of the quadrivalent vaccine, we saw a reduction of new cases of cervical disease. And this was important whether it was related to vaccine type or other types. And certainly what we know, and this is Dr. Kang and her group in Korea, that when she took a group of women who had had a LEEP procedure and she divided them in half and vaccinated one half and didn't vaccinate the other half, she saw a threefold reduction in the vaccinated group. So it's never too late. That's what we need to tell our patients. Even if you've had cervical cancer, we want to reduce your risk of cancer in another location. And even if you've had a LEEP procedure, it's not too late for you to take vaccination and get benefit. This was Franz and his group, and he looked at the risk of the same serotype or another serotype in the same location or another location. And what he was able to show was a 6-fold reduction of disease by vaccinating and preventing relapse. We also know that he was able to prevent a 70% reduction of genital warts. So I think we need to be reassured that there's efficacy no matter what age you are and no matter what stage you are. Even if you've had disease, there's a benefit in vaccinating. Even if you've had exposure, there's a benefit in vaccinating. And that's some of the data that I think we need to incorporate so our patients understand it's never too late. So what are the actual recommendations? When we look at NACI recommendations, we need to understand that NACI is the advisory committee with all the experts, and NACI gives recommendations for vaccine use in Canada. Well, NACI has said, and remember the product monograph is 9 to 45. Well, NACI has said you can consider this in females and males less than 9 years if they have risk of exposure. That I find very troubling, but we need to understand that different communities have different values, and it's possible that there may be risk of exposure even in these very young children under age 9. For those 9 to 27, it is recommended male and female. And above the age of 27, it may be administered with no upper age limit. That means for community-based family doctors like myself, if we're seeing somebody who's getting a new partner, maybe after a divorce or after a death, we are not looking at age, we are looking at risk, and risk relates to being exposed. In Manitoba, they now have a new program that includes females 9 to 45 with new high-grade histopathology. If you have disease, you need to be immunized, and that's to lower your risk. And in PEI, they have a high-risk program where they're looking at history of genital warts or an abnormal Pap test. If you're 18 to 45 and you've either had unprotected sex with multiple partners, more than one partner, or a history of genital warts or an abnormal Pap test, you qualify on getting the province to pay for your vaccine. I think it's really important as we start to broaden what we consider high risk, broaden that to include any abnormal Pap test. So depending on where you are, you may have government support, but whether you do or you don't, we need to talk to patients so that they understand their risk and they understand how to protect themselves. We know that the Gynae-Oncologists of Canada came out with a white paper. They talked about how important the school-based HPV vaccination uptake rate is and how important that program is, and how the private adult HPV uptake is much lower. Their goal was to enroll, engage, and empower patients with information so that they can consider getting vaccinated. And they have recommended universal HPV vaccine in Canada. Well, unfortunately, we've just taken a step back. I know in Ontario and I believe in Alberta, public health is stepping back from doing the school-based program. And that's because of COVID and all the public health resources going to COVID to contact tracing, et cetera. So in Ontario, the children in grade 7 did not get their second shot because school was closed from March onwards. And now we know that the children entering grade 7 are not getting their routine vaccinations in the school. That means it becomes opportunistic. It becomes on how careful doctors are to call in that age group and to immunize them for HPV, as well as in Ontario, meningitis and hepatitis B. I think this is really a concern, and I would encourage everybody to start to pay attention to what public health is saying about providing vaccine so that there can be a plan for calling these children in and getting them immunized. There's lots of barriers to vaccination. It's very interesting when you ask patients what the barrier is, they often say it's physician recommendation. The number one barrier is the doctor didn't mention it. Whereas when you talk to doctors about barriers, they think it's cost and they think, well, the patient couldn't afford it, so I didn't bring it up. I think we have to learn from this, that the number one thing is to talk about vaccine. That's what we're doing all week. That's the whole purpose of HPV Week in Canada. We need to talk about making that recommendation, because when we make the recommendation, this was a study looking at pneumonia, 93% of people were ready to take the vaccine. We didn't get 100%, but in the actual study, it wasn't 93 out of 100 because the actual recommendation was only made to 25% of the patients. If we as providers, pharmacists, nurses, public health, teachers, all the different groups that are involved in vaccine, if we don't make that strong recommendation, then patients don't have the opportunity to understand it and to then say yes or no. And we can get 93 out of 100 saying yes to vaccine. We need to work on our recommendations. So I think we have to have a great conversation, and the past conversation said, well, maybe it's not too late and there's limited data on post-treatment benefits. And I talk much more aggressively at this point. I talk about prevention against additional cancers. We've discussed why it's not too late, even if you've already had disease, the additional protection of the 9 types of HPV, the growing evidence in post-treatment benefits in terms of less risk of recurrence, less risk of new disease, protecting your partner, and prevention of adverse pregnancy outcomes. That has to do with the treatment for HPV, for abnormal Pap tests in young women that often leads to early miscarriages and early fetal demise. So I think we need to be able to answer the questions. I think we need to be able to answer for our patients. Is it safe? Yes, we know it's safe. 270 million doses, that's very reassuring. Does it work? Yes, we know that from the studies I've just showed you. We understand the value of the vaccine, and we understand that we're starting to see reduction of invasive cancers now that we've been vaccinated for more than 10 years. And Doc, what do you think? Are you using this in your patients? Are you taking this yourself? Are you giving this to the appropriate people? I think we need to be able to answer that question. So thank you very much. I'm going to end the slideshow. I'm going to stop sharing the screen so we can open it up. We can see each other, and we absolutely can open up the chat box, questions, or unmute yourself and ask your questions.
Thank you, Dr. Brown. And with that, the chat box is open. You can also use the unmute yourself and raise hands to ask any questions.
For those of you that weren't here at the beginning or that weren't able to stay for the whole presentation, this will be on the Federation website. And I do want to invite you to tune in every day at noon for the various webinars. Dr. McNeil mentioned Dr. Ogilvy's study in terms of sampling, and I think that's just really important and really interesting. We're honored that she's going to speak with us tomorrow.
And I would actually mention as well that the link you used to get here is the same link for all of our sessions this week. Now I don't, oh. Please go ahead.
Hi, I'm actually a reporter for the Medical Post, but I have a bit of a personal question. What about grade 8 students who didn't get their second dose of the HPV the HPV 9 vaccine? How long a time period do they have before they should get this? Can they wait before they get the second dose?
So that's a really good question. And generally, the vaccine is advised to take the second dose 6 months after the first. You can wait longer. There was a study in Quebec that waited quite a bit longer. But the problem is as they get older, their immune system is not as robust. So the reason they get to take only 2 shots is because they're 14 and under. So the problem is they're aging out, they're getting older. And so we want to get them immunized as quickly as possible. In my practice, as soon as I have a vaccine from public health, I'm going to do an EMR search to pick up the right age groups and start calling them in.
Thank you very much. We do have a question from Cheryl Morris in the chat box. Can patients know what type of HPV they have, or are they still grouped together?
So when we separate out the different types of HPV, that's usually done in research. When we do an HPV test, the answer is either oncogenic HPV or non-oncogenic. So you don't really get the exact subtype. That's very specialized testing, and it's quite a bit more expensive.
And we have another question in the chat box from Eleni Levero. I apologize if I butchered your name. Hi, I'm a PEDS resident at CHEO here in Ottawa. Just wondering if there is any data or reports of reduced uptake of the vaccine amongst middle school and high school students, and if so, how can pediatricians help? Is it parent-family education? Is more advocacy needed? Thanks.
So the school system is generally globally the best way to get people immunized, the best way to get kids immunized. And that's been borne out with various different vaccines. Right now, because the school system is not going to be immunized, I think we're going to see a significant drop off of vaccine, and I'm very concerned about it. I just heard globally that there's been a drop off of more than 60% of MMR globally. And of course, that speaks to the fact that we're going to be at risk for a measles outbreak. Because of COVID, people have been very reluctant to go to the doctor. So I think we have to use all avenues. I would encourage pediatricians, if they're following young people, grade 8, grade 7, grade 8, to call them in. And in general, whenever I'm seeing any patient, mothers, fathers, grandparents, young kids, I talk vaccine. I'm talking about MenB vaccine. I'm talking about HPV vaccine, so that anybody that slipped through the cracks and didn't get their school vaccine will certainly have that discussion before they're off to university. I think we have to use every opportunity when a patient interacts with the healthcare system to talk about vaccine. They may not have booked the appointment for vaccine. Maybe it's for birth control or for a Pap test, or to talk about some other issue. But I think we need to be using those opportunities to talk about vaccine, because even in our school system, and even when it's working properly, we don't have 100% uptake. Good question.
Any other questions? Oh, what type of cancer does AGUS cause, i.e. endocarcinoma or squamous cell cancer? And that is also from Cheryl Morris.
It's a good question. I am not 100% sure of the answer. I'm sorry, Dr. McNeil is not on the line with me. I can't answer that question.
And we've got a couple more minutes left. If anyone would like to ask any additional questions, if you want to just turn your camera on, I can recognize you, and or you can type in the chat box.
I think it's really exciting that we have a vaccine that can prevent cancer. And I think it gets lost sometimes in public perception about what this vaccine is all about. We need to go back to basics when we're talking to our patients and when we're talking to the public, and talk about the fact that we have a vaccine that will prevent cancer. In Australia, they now have such a high uptake of vaccine in men and women, boys and girls, that they have come out to say that they're going to be the first country in the world in approximately 10 to 20 years that will be able to say they've eliminated cervical cancer as a public health issue, and they see less than 4 per 100,000 cases. I think we've got the ability to do that too when we start to get people on board understanding this is all about cancer prevention. And that's what the message needs to be, so that people understand when they take a 10 or 11-year-old to the doctor and the doctor starts talking about HPV, yes, it's sexually transmitted, but the whole idea is to prevent that cancer now because your immune system is robust and you'll get a better response lifelong. And that's some of the data that Shelly was showing you at the beginning, the data in older women when this cancer recurs. Let's look at immunization as being one of the things we do to prevent cancer. And I describe it like I describe other measures to protect our children, like seatbelts and car seats and bike helmets. We immunize to protect the disease we never want to get. Thank you so much. Thank you everybody for being on the call. I hope you'll talk about this with your friends. I hope we'll have lots of people on tomorrow's talk with Dr. Ogilvie. And I hope this entire program this week, which we've had wonderful opportunities in the media and wonderful opportunities to talk about HPV. I want to thank our collaborators, which is the SOGC, the Society of Obstetrics and Gynecologists, and the sponsorship and collaboration with Merck. You know, I think it's really important that nobody achieves something alone. It was Al Gore that rephrased an African saying that says, when you want to go fast, go alone. When you want to go far, go together. We want to go far and we need to go together. Thank you so much for being with me.
And thank you, Dr. Brown and Dr. McNeil. You know, since this will be recorded, you'll be able to see that. You know, we do have some great presentations for the rest of the week, and as well as our partners at the SOGC. You can go to canadaversushpv.ca for a full rundown of you know, of all of our activities, as well as there's a public service announcement and some toolkit for HPV awareness. You know, thank you everyone for your attendance and your attention, and we look forward to presenting tomorrow's webinar as well as the rest of the week. Thank you.
Thank you, Michael.